Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual. And today, more important rules that hopefully will help you take care of your patients. Rule number 129, the very famous Colic Rule of 3. Crying for more than 3 hours per week, for more than 3 days per week, and for longer than 3 weeks in an infant who is well fed and otherwise healthy. That is the tricky part. So this is by all means not a rule that I came up with or anybody that I know came up with. That's a rule I learned in residency as well. And this is basically a simple definition. Any baby that is crying for more than 3 hours per day, for more than 3 days per week, and for longer than 3 weeks is considered a colicky baby. Again, that is taking into account that the baby is well fed, he or she are not crying because they're hungry, and they're otherwise healthy. In other words, there's no fever, there's no injury of any sorts, etc. Now again, this is a simple definition that I certainly keep in my mind when I see a crying infant. I take a history and discover that the patient has been crying that much and he or she fits the definition. Under those circumstances, assuming and only assuming the rest of the exam is normal, and by history and maybe labs if I need to, I ruled out any organic, acute, life-threatening, or serious, or even semi-serious condition. I feel comfortable under those circumstances making that diagnosis and discussing that with the worried parents. As in the past, it almost always goes back to rule number 1. It's not the patient's job to prove that they're sick, it's your job to prove that they're not. So remember, rule number 129 and the diagnosis of colic for us pediatric emergency physicians and EM providers in general is a diagnosis of exclusion. I encourage you to listen to episode 3 when I reviewed the rule of 6 that helps you remember the most common cause of a surgical abdomen by age, including newborns, so when you see that crying infant, you have a good plan to rule out the most common cause of surgical abdomen. Now, if indeed everything else is well, again, your physical exam is normal, your history is reassuring other than crying, maybe you even did some workup and found no injuries or no infections, etc., you can comfortably, maybe, make the diagnosis of colic. But remember, to make the diagnosis, the patient has to be crying for more than 3 hours per day, for more than 3 days per week, and for longer than 3 weeks. That is a simple definition. By all means, if as an emergency provider you did not find and do not think there's anything else, you can talk to the parents about colic. Now, if indeed everything else is well, the question is, what do you do other than talking to the parents? I must admit, as an EM provider, I don't really know the management of colic, but at least I know I can provide reassurance for those very worried parents, and I know I don't have to worry that I'm missing anything. So remember, colic is a diagnosis of exclusion. Any patient that is crying for more than 3 hours per day, for more than 3 days per week, and for longer than 3 weeks, assuming everything else is well, patient is well fed, history and physical and maybe workup are reassuring, you can possibly make the diagnosis of colic, provide reassurance, and send those patients and those parents home. Rule number 130. Follow the guidelines. If you are in the business of taking care of children, better follow the AAP guidelines. I would add to that rule, better follow the AAP guidelines or some other evidence-based, tested, validated tool. For example, pediatric appendicitis score. There are so many examples for that rule. Bronchiolitis guidelines by the AAP acute otitis media guidelines, and many, many more. These guidelines help you do the right thing clinically for your patients since they provide an evidence-based approach so you can be confident you're following the evidence. For example, sticking to the watchful waiting approach for acute otitis media helps all of us providers not overuse antibiotics for acute otitis media. And with time, hopefully put a stop or maybe even just slow down the phenomenon of antibiotic resistance. Following AAP guidelines for fever in a newborn helps all of us make sure we don't miss any SBI or serious bacterial illness and work up the patients appropriately. Similarly, I try to recommend to others to use any validated tool by the AAP or others. For example, something like the pediatric appendicitis score that relies on your history, physical exam, and a simple CBC to try to figure out if the patient does or does not have appendicitis. Another good example is the Picarn head injury rule that many of us are very familiar with that helps you decide if you need to or do not need to do a CT. So I always try to use those kind of tools or guidelines when I take care of my patients. Now, beside doing the right thing clinically and following the evidence, following guidelines can lead to some homogeneity in treatment. So we don't hear things like, last time I came to the ER, they did so and so. By following the guidelines, we all make sure we all provide a very similar treatment so patients are not misled and don't have any different expectations under different circumstances. Lastly, following AAP guidelines or other validated tools protects you clinically. So if you follow the pediatric appendicitis score for a child with abdominal pain, and let's say discharge the patient who unfortunately came back a few days later with a perforated appendix, from a medical legal standpoint, at least you will be protected because you followed an evidence-based guideline. I think it will be very hard to build a legal case against you if you missed a diagnosis of any sorts but followed a validated tool used in the emergency medicine community. So in other words, following AP guidelines and other validated tools helps you protect yourself, which is always just a good idea. But in addition, obviously, it makes it less likely for you to miss something to begin with. Rule number 131. Displacement hurts. I encourage you to listen to episode 27 when I discuss the approach to a pediatric patient with a fracture with Dr. Sean Keys, who is a friend of mine and a fantastic pediatric orthopedist. Again, always a good idea to start with examples. Many times I see kids who come to the pediatric emergency department with a musculoskeletal injury, and I can tell by the history and the physical exam that the child very likely has a fracture. He or she are either swollen or have point tenderness, etc. However, if I see no deformity and the child for the most part seems fine, mild pain, mild swelling, cooperative with the exam, I reassure the parents that the child likely has a fracture. However, likely it's a small fracture with no displacement, and I explain what that means. From my personal experience, a child who has a displaced fracture of any sort is in significant amount of pain, crying, uncooperative with the exam, and of course, sometimes the extremity looks deformed. So when I see a child who has the signs and symptoms of a fracture, which are point tenderness, swelling, or inability to use the extremity to the same degree, but the pain seems to be mild and the deformity is essentially non-existent, I feel comfortable telling the parents that likely the patient has a fracture, but likely it's a non-displaced fracture. Keeping in mind that anytime there is displacement, the patient is in significant amount of pain, he or she rarely let you touch the extremity, and there's a lot of crying and lack of cooperation, which is obviously very understandable. But generally speaking, if the patient has signs and symptoms of a fracture, which are point tenderness, inability to use the extremity, or swelling, but he or she seems to be okay, no significant deformity, pain is very well controlled even without medication, likely the patient is a non-displaced fracture, and that's a good idea to discuss with the parents right off the bat, because usually, especially in young children, non-displaced fracture translates to splint and send kind of approach. Usually you can splint those kids somehow and send them to follow up with the primary care or maybe even the orthopedist, but there's no other significant treatment that needs to be provided in the pediatric emergency department, and I'm really talking about sedation and reduction. So keep rule number 131 in mind. Displacement hurts. If you see a child that likely has a fracture, but the pain is not very significant and there's no deformity, you can rest assured you're likely going to diagnose a non-displaced fracture. Buccal fracture would be just a very good common example. And that is it for today, guys. Thank you very much for listening. Let's review a little bit of what we learned. Rule number 129. Rule of 3 for colic. Crying for more than 3 hours a day, for more than 3 days per week, and for longer than 3 weeks, make the diagnosis of colic. Of course, as always, by definition, the infant has to be well fed and otherwise healthy. And if you do think there's anything else, maybe even work up the patient, but if you found nothing, remember that definition, make that diagnosis, and give a lot of reassurance to the parents. Rule number 130, follow the guidelines. If you're in the business of taking care of children, better follow the AAP guidelines or some other evidence-based, tested, validated tool. These tools help you do the right thing for the patient clinically, avoid missing any diagnosis, and protect you from a medical legal standpoint. Rule number 131, remember, displacement hurts. Any child with a musculoskeletal injury who has swelling or point tenderness or inability to use the extremity has a fracture, but if you see no deformity, the pain is very mild, the patient is very cooperative, likely he or she have a non-displaced fracture. Usually, especially in young kids, those fractures translate to splint and send type of approach. Splint the patient today, send him or her for follow-up. And that is it, guys, for today. Thank you very much for listening. I hope you like Nirvana. This is one of my favorite songs, Come As You Are. You might have heard this outro before, but this time I added the very simple yet amazing solo by Kurt Cobain.